Welcome to the Veteran Psychedelic Discourse. We are a group that advocates for safe and responsible exploration of mental health treatments, and this is not a platform for the solicitation of illegal substances.
So we have a returning guest, Zach Skiles, who's a PsyD we've had before, talking about Heroic Hearts Project. He was part of the facilitation group for when I went on in the July retreat for Heroic Hearts, Portland, Oregon. That was very awesome. He's joined today by Neeka Levy, RN. It's been a little bit of time since then. You've had some adventures, obviously. I want to be able to just hand it off to you guys and see where this goes. Neeka, do you want to talk about a little bit of your getting involved in this? Because since this is our first time meeting you.
Yeah, sure. So I'm Neeka Levy. I'm a registered nurse. I'm also a doctoral student at Johns Hopkins University. I'm getting my psych-mental health nurse practitioner as we speak. It's great. I am also, so I have a degree in nursing and I also have a degree in neuroscience. And throughout my career, I've always been interested in research and working on the brain and trying to figure out what's the best way that we can start really bringing some healing. And I also have a really big passion for nature, all the hiking, snowboarding, skiing, you name it, I love doing it. So that's what inspired my move from the East Coast to Portland. And as I came to Portland, started doing as many outdoor things as possible, but I also realized I need to do more. I worked in acute psychiatry. Unfortunately, it was a revolving door, so we weren't really helping too many people, just kind of housing them until they can somewhat get stabilized and then go back out again. So in that process of wanting to do more, I stumbled upon a lab at the Portland VA, which was working with psychedelics. A little part I forgot to mention is that my parents are refugees from Ukraine, so I'm the first generation in the States. And what that really means is that while they lived in Ukraine, which was formerly the USSR, they didn't have access to medicine because they were Jewish and they had a lot of anti-Semitism. So what they did was they turned to plants. So a lot of their medicine came from plants. A lot of the things that they can access was just what is outside. So there was always a big natural component that was in my life as I was growing up. So when I came to the Portland lab and I saw that they were working with psychedelics, it kind of just all fell into place for me where I get to use plant medicine to really help people. And like, we know that it's helping people. We see that it's 60% effective for folks, and it's more effective than what I see in my acute psychiatry every day. So I jumped on the opportunity. I worked there as a clinical and medical assessor, and then Heal Ukraine Trauma came around, and we'll get into more of that. But Zach and I developed a program to train clinicians on how to administer group ketamine-assisted therapy so that we can help people coming out of the war.
Yeah, so as an intro, I met Neeka. Hi guys, Zach Skiles here. I met Neeka at the Portland VA where she got hired on as a nurse and was doing our medical and clinical assessments. And way back when, as I had graduated from my doctorate of psychology, I was invited into a gathering where I met Elizabeth Ames, who was at the time the founder and executive director of Heal Ukraine Trauma. And I was about to shoot off into the world. This was 2021. I was about to shoot off into the world to do a postdoc, ultimately at UCSF at the Translational Psychedelic Research Program. But after meeting Elizabeth, she was very adamant about moving into Ukraine and addressing the transgenerational trauma after decades of conflicts, of multiple conflicts that were going on in Ukraine. And she was consistently inviting me in, come to Ukraine, meet a Ukrainian wife. This is going to be a really great thing for you and all of us. And I was just flattered and wanted to jump into it, but I had to continue my path. So I said, thank you, maybe another time. And fast forward into meeting Neeka and having tea and walking our dogs together at the Portland VA and learning about kind of the family she had involved in the Army, and just the impact that was happening. I connected the dots and I was like, there's a great organization actually that I think you would dive right into. And so I introduced the two and watched her just whip this organization into research readiness and developing advocacy mm, routes of ground to build with the Ministry of Health out there. And ultimately, they were sending you out to deploy in country. And I was not going to let you go out there alone. And I spent a couple years of my life in multiple combat zones. One, I'm a former Marine, so invading Iraq was one, and then building a PTSD clinic in South Sudan while a border dispute broke out there that turned into a small war of a skirmish. And now this beautiful deployment that we got to do in building a three-part training program for Ukrainian clinicians with the use of ketamine. So in applying it to groups being the most cost effective, as well as the application of groups with psychedelic assisted therapies. It's been historically the most impactful and the I think the most appropriate use, really, for a number of reasons. So in that three-part training program, one being academic, it is actually the first veteran-centered training program for psychedelic assisted therapies in the world. We've kind of answered what MAPS has developed. Their claim to veteran-centered training was due to the fact that they watched veterans being treated with MDMA, and they had a component where they talked about moral injury from the veteran perspective. And our answer was, well, there's also the cultural aspects of like what it is to be traumatized while a service member. What are the kind of daily sensitivities and nuances that a lot of our service members are exposed to, and how it is that they hold that as they transition into the veteran community and civilian life, what the impacts are there that our counterparts at the VA or in clinical practice are offering. So we developed multiple classes around the lens of trauma from the military and veteran gaze, as well as what safety and drug-on-drug interactions to kind of note when people are managing multiple ailments.
And if I may also jump in, we didn't want to be, the classic Americans coming into a different country being like, here's our program, must follow the American way. We actually developed it to be culturally sensitive for Ukrainians as well. And we did check that with a couple doctors over there to really make sure that what we're delivering isn't just an American thing. It's something that makes sense to Ukrainians and Ukrainian veterans.
Right. Yeah. And so moving through the academic portion, we also used the therapeutic protocol, a group therapeutic protocol that we would take eight clinicians through so that they have their own therapeutic experience through that protocol.
If they qualify.
Yes.
Yeah.
And then they're able to then step into the third phase after the experiential, which is the second, and have groups of veterans that they actually treat with their protocol, the group protocol that we created with HUD.
So that part is the supervision portion where we just make sure that what we've provided for them for the protocol is what's being followed. It's being adhered to best practices. All ethical guidelines are being followed and such.
Yeah.
From our conversations with Annie and Michael Mithofer and Bruce and Marcel, the biggest thing that was happening with underground ethical boundary transgressions and such was that there was no supervision. There was nobody that you can answer to and turn around to and be like, hey, this is happening. I'm not sure how to handle this. So we really wanted to make sure, like, we're bringing this program to a country. We want to make sure we're doing it right. Let's make sure that all the possible ways are being followed, all the dots are being dotted, or
T's crossed,
T's crossed, I's dotted. That
really with the help of Michael Mithofer, as well as he's graciously stepped into our own supervision as we facilitate each group cohort that goes through together. it's a bit of a bucket list check for me. I didn't really realize was even on my list, is to be supervised by Michael Mithofer, who's just an amazing clinician and who has continued to help, I think, with the nuances of understanding when it comes to the interdirected process that is so critical in psychedelic-assisted therapies, as we're building it out in the psychotherapy sense, kind of how people are finding their footings as clinicians.
I got to ask, so what was the time frame that you guys were out there?
We were there for 2 weeks in September. It was like the first.
Yeah, that's right. Yes. They had really good, this was the nicest war zone. I don't wanna overplay it or underplay it, but this was the nicest war zone I'd ever lived in. And they had very well
established Patriot missiles
Yeah.
with like almost a 99% accuracy. So people were walking around every day. If the alarms went off, most didn't respond because it was likely that everything would get shut down, knocked down.
So there was a good sense of safety, I think, for the most part, but there's still a margin of error for those armaments. And so we just wanted to be as safe as possible. So we actually brought our clinicians down to
A bunker.
in the ketamine clinic and developed a nice little ceremonial space that still incorporated aspects of nature, as if we were in a cave that looked out into a
mountain range.
mountain range, a little beautiful spot that worked out pretty well.
I just had a real quick question. I'll introduce myself later whenever that's appropriate. But what was your success rate that you found that especially coming right off the battlefield, you know, and dealing with all of that? What were you guys looking at? Like, what was your kind of anticipation of what you would be able to do, and what was the actual reality of it? That's it right there.
This was in Ukraine.
Yeah.
So we've just started the supervision component, and they're treating veterans who can step into private clinical care. It's a little different setup than it is in America, because they're actually not able to get ketamine treatment in
Ukraine
hospitals under the Ministry of Health, and so they have to actually step into private independent clinics. And so the recruitment process has started. They're actually going to start their first group, I think, in 2 weeks, I believe.
Yeah. So once that data starts coming out, we're happy to share it with you. As of right now, all of our clinicians have to qualify for MDD, or major depression diagnosis, in order to be treated with ketamine. That's just the laws in Ukraine right now. So all of this time around, magically, they qualified for depression, and almost all of their scores actually improved, which was amazing to see. And a lot of them had big realizations of working too hard, and like that work being completely tipped over, because you have half a country at war, the other half is being exposed every single day, and you only have a certain amount of psychiatrists and psychologists. Some people were seeing up to 36 patients a day, where that is just an insane amount of patients. So a lot of them started to realize where they're falling through the cracks, and have started pulling back and prioritizing some of their own work-life balance so they can be more effective clinicians. So at least from that perspective, we've already started seeing some significant changes.
Yeah, I feel like what we're doing personally in the training program is just building resilience, honestly, because you're living in a war zone, and it's going to impact you. It doesn't mean that you're broken in any way. It just means that you've got a lot that you're putting on your shoulders right now. And everybody is going to have some blind spots in that process, whether they're seeing 30 patients a day, or when the entire country has only 600 psychiatrists. There's going there's going to be a lot to double check.
And I anticipate in the near future that there, you know, as things get better, I believe things are going to get better. I think it's going to, the amount that you're going to be dealing with once the conflict is over, whatever resolution, I think that's, I mean, you better have some more people backing you up, because I think it's going to be a flood for you.
Yeah,
totally.
There's stuff to kind of think about when it comes to the timing of that, as we've delved into the research and kind of when is it appropriate to actually apply ketamine or psychedelic assisted therapies directly after a traumatic experience.
And there is actually some research pointing to, like, if it just happened and then you give ketamine, it's a little too soon. You might actually re-traumatize people. So there actually needs to be a time period that happens in between, about like a year or so, before you can start taking it and then getting into it, which is actually really great too, because we're not trying to use it as a first line. We know that if you have psychological skills going into it, you're going to have better outcomes. So it's really great to start building up some of those classic therapy skills before jumping into it.
Yeah.
Outstanding. That's all I had.
Yeah, no worries.
Thank you.
Yeah, if since this is going to be on YouTube, any type of publication comes out on any of this work, if you get anything, Zach, or if I find anything, I'll make sure to add it to like the description for this video, just so that people could see what that looks like.
Awesome.
So if anyone has any further questions, just let us know. But was it just military? Was there any civilians involved in this?
So we had 2 military folks, 2 veterans, and the other 6 were civilians working with veterans.
And these were all clinicians. So the idea is that we're training the clinicians so that they can go and then treat veteran groups.
Yeah.
And eventually we're hoping to expand it to military families. So let's get the spouses involved. Let's get children who are old enough to be involved.
Yeah.
Just trying to dose children. But our hope, at least in the second phase, is to allow our clinicians to understand what they're giving to their patients, because research is showing that patients who know that their clinicians have done this themselves have better outcomes. There's an increased trust factor. There's so many wonderful things that could come out of when your clinician's like, hey, I've done this, I got you, and then the other part is too, that it is a war zone. They are going through their own things. So let's build some resiliency and start developing some burnout techniques and all of this stuff before they go in and start treating a bunch of people.
Yeah, there's I think aspects of this process that we've gleaned after working in the field ourselves for a long time. And I think it's something that in general is impacted the United States care, as well as is the kind of need for mental health providers, and the just amount of saturation and burnout that we can see here. So we just try to impart as many lessons as we can in this process with them. I think one good example came from one of our trainees, who is a phenomenal medicine woman and just an apt clinician all around, but was seeing, again, 30 patients a day. And I think anybody needs a good reminder that no matter how amazing you are, there's still going to be shadow elements to this work that we really need to sit with for long periods of time. And so offering the idea that when it comes to 6 to 8 hour medicine sessions, to limit that to 2 or 3 a week at maximum.
Well, I actually want to jump off something off of that too. So it's actually already being practiced in Ukraine. And the way that it was being practiced was this specific participant was seeing at 2-hour time slots 4 patients a day, giving ketamine 4 times a day. So like she's doing that 5 days a week. So it's already happening. She's burning out. Other people are burning out. Like they didn't have any preparatory stuff, very small, like come in, sign paperwork, and very little integration. So it's already happening. So that was one of the other reasons we built the model, was harm reduction. Let's make sure that everybody going through this is getting the adequate resources and support before just diving into their deep subconscious and coming out and hopefully being put together in about an hour.
Yeah, I think that's really the basis of our whole operation too, is I was meeting with different folks who had legitimate justified concerns why a US operation was coming in to do anything in Ukraine, especially when ketamine is so young in their system. And so really highlighting the fact that it's already in use, and in fact, because of the lack of education and training, it's being used improperly in a lot of ways. And if we can start to understand the impact of this and start to integrate some best practices, I think that we'll have a better chance at success and doing no harm.
No, I appreciate that it's with these people that are going to be providing it to others, because I mean that just goes a long way, especially if you're trusting your own health with someone and you want them to be able to you want them to believe that what they're doing is going to help you. And if there's no familiarity at all, it's like okay. I mean, how
Yeah.
so I definitely appreciate that. So you were mentioning previously that as long as they're meet the qualifications. Can you share what some of those might be?
Yeah, so the basic qualifications we run everybody through is do you reach criteria for a depression diagnosis? That's like the biggest thing. That's what the law says in Ukraine. You can't get ketamine unless you have major depressive disorder. After that, we just
Exclusively.
yeah,
Nothing
Yeah.
else that,
as of
oh,
right
okay.
now, yeah. So our another part of our organization and UPRA, which is their psychedelic advocacy organization, they are trying to advocate for an expanded access to PTSD and other stuff. So it's what we got to work with right now. So that's what we're trying to at least start with.
There's, I think a lot of the times for folks when they're moving through this process, um, there's of course a need for trauma-related care that we're assessing for folks in a general clinical interview, kind of what their experiences are with medicine work as well, because we want to create that psychedelic peership that you were talking about, and uh, having the personal experience and belief that builds trust and actually betters clinical outcomes. When Alex, like you were saying, when you're with somebody who has had personal experience, there's a bond there, there's a trust, and because of that trust, you're able to go a little bit deeper and actually take on things that you might not when it gets a little challenging. So, and experiencing that personally is one aspect that gets addressed when they're going through kind of general professional interviews to join the program.
I was just gonna go back to the exclusion criteria.
Oh yeah,
And the
totally,
inclusion criteria whenever you're done.
absolutely. Go for it.
Okay. So outside of the major depression diagnosis, we have to make sure that there is no psychosis, no bipolar 1, no borderline personality disorder. As of right now, there isn't enough research supporting that somebody with these diagnoses can safely go through. I actually do know one clinic that was operating in Portland for borderline personality disorder, but it required participants to go through a whole year's worth of therapy before they could even step into the psychedelic space. So when we're considering those types of diagnoses, we have to look at what supports can we offer as a clinic, especially in a place like Ukraine, which is an active war zone, and how many psychiatrists do they have, and all of this stuff, right? So we're trying to introduce it as safely as possible to increase as much access, but also look at it from the perspective of like, what is the research out there supporting and what is actually accessible. And then just your typical medical parameters. We want to make sure there's no sleep apnea because it can cause respiratory depression, which is where it decreases the respiratory rate. We want to make sure you're safe, cardiac wise, making sure your heart's strong enough to go through it. There are no bladder problems and no substance use disorder. Specifically with ketamine and other medications, but all the research right now with substance use disorder with ketamine is recreational ketamine. There isn't a lot out there that says pure ketamine from a medical grade version does cause substance use. So it's really hard to say for folks with using ketamine. There is some preliminary research that says it's okay actually to treat people, but we're not trying to step into that territory unless we have a sufficient amount of evidence.
Yeah. And if there is kind of an issue with ketamine in general, drug-on-drug interactions, or maybe a participant just doesn't want to have ketamine, we've made available holotropic breath work as an experiential, so people can start to have some sort of personal experience behind an expanded state of consciousness to kind of hold whatever rebirth process might happen.
I think that's like a really important point too, is psychedelics are just one way of getting there, right? We do know with prolonged meditation, like going to sesshin and meditating for 12 days in a row, you can actually break through in a very similar altered state as you do with psychedelics. With holotropic breathwork, there's it's the same altered state. So there are many ways you can actually get there without using psychedelics. It's just one way of doing it.
You spoke just briefly about resilience strategies that you guys used. What type of stuff did you introduce that you found successful? What did some of that look like?
Gosh, I'm thinking back here to all the reports that we've had since then. So of course the bonding agent with the group, right? Tapping into the group intelligence. So really developing a community-based care, but having that be around appropriate positive experience building. So when talking about having not only the burnout addressed, but what are we doing to actually strengthen ourselves and each other? So stepping into different practices for different people looks like a variety of things, but for some folks, they actually got together outside of the country and stepped into ceremonies together, as well as just took some time for a break, really took a vacation and really stepped into their own healing.
I think one of the biggest things that people get out of the group is a new community, and especially in Ukraine, where community is at the center of their culture. Having a new community that you have gone through a significant experience, you have people to hold you accountable, making sure that you do take your breaks, making sure you do have a good balance. And one of the other parts that we do is make sure that we connect people to resources. So what is the next steps after we leave, after even they leave their clients? What are the next steps that we can continue to ensure that people are getting the adequate resources? So that looks like alternative types of practices, yoga, meditation, acupuncture, all of these different types of things. Let's connect you to your community and keep that care going.
Yeah, I think more recently too, in our third phase. So there's a lot to kind of to get into with the therapeutic protocol that I think assists in the greater exploration and healing process. But the building of resilience has been, I think, in the practices of our supervision. So as we are supervising folks as they're bringing groups of people together, every so often, every third meeting, we'll have a traumatic release exercise done by a really great practitioner in Bosnia named Ezra. And outside of that, we've also been sharing my model of the shadow warrior. So there's an aspect that I'm publishing here shortly, and holding it as kind of a model for not only interfamily systems, but just a work of shadow archetypes when it comes to the warrior. So having an ability to check in with yourself if you are a protector or warrior in your clarity, having a bit of a coach that can kind of talk you through things, and an inner coach. Be like, how's it going? Are you checking all your bases, dotting your I's, crossing your T's? And then if you're feeling like some shadow work can be done around perpetration. So feeling as if you're the bad guy in something, or there's some shame or guilt around surviving, and just the fact that you've had to take a life or step outside your values. Really developing an internal challenger to check in with how you're treating yourself through that perspective, any kind of shame or guilt, and the actual justification of that. And then the shadow work of victimhood, being in the system for a long time and just going through the motions of a warrior, to offer first a kind of sacred witness to see kind of what that journey has brought, and then stepping into the creator, an archetype that offers possibilities in different ways of being. So these are all kind of internal healers of the inner healing intelligence that I think has been a great crafting of resiliency, and an offering that we've been developing with these folks in supervision.
you talked about the use of ketamine and stuff like that. Are you guys also, I'm assuming you are using, other types like psilocybin or anything else out there besides ketamine?
We are working towards it. Right now in Ukraine, it's legal. But there are options for people to take groups of Ukrainian veterans outside of the country, which already has started happening, so that they can be treated with psilocybin or MDMA or whatever else type of medicine.
Psilocybin, that's right.
Yeah, that's all right.
Okay.
If they're taking them out of Ukraine, where do they go for that?
Right now, one of our clinicians are developing a group in Romania.
Okay. Now I'm starting to connect some dots. Tom, I didn't want to start rolling without checking in if you had more to your question or if you were.
No, that was good. I was just wondering, if there's other things that they're establishing or, moving forward from here, like making sure all options are on the table and, because not everybody's, not everything's going to work for everybody.
Yeah, totally.
You guys know.
You have to find your medicine and what
exactly
medically predisposed. Thank you.
It's taken me a long time to finally get to where I'm at now. So yeah, it's been a journey.
Yeah, you bring up a really good point, because there's a lot of research that's starting to show that even though ketamine might be really good for acute suicidality, it might not be your medicine. It may not actually work for you. So there's a spectrum of what medication is good for what disorder, but also what medication is good for you. So it's that whole individualization of medicine, which we're trying to advocate for. I know Heal Ukraine Trauma has been doing a really great job at working with UBRA to petition to the Ministry of Health and start expanding some of those medicines. But as of right now, they're not legal.
How we've also developed the protocol, the group protocol, has been the fact that we're actually just concentrating on the psychotherapy around it, so that there are elements to bring into a group experience, and you can, when the time is right or appropriate, use whatever medicine to step into in that sense.
Take out ketamine and replace it with something else.
Yeah.
So
it's a toolbox.
Totally.
Use it in the toolbox.
Can you elaborate a little bit into what the situation with Romania looks like, just to get a little bit extra context? Is it like just one for one, same group size? If you're considering psilocybin for them, then you just have a space set up and protocol similar to Heroic Hearts type of thing? What does that look like?
So the protocol itself, do you want to jump in here?
I was just going to say the protocol itself doesn't change. So it's whatever manual that we've provided for them, they follow that. It's up to actually the clinician to figure out what clinic they're going to. We can provide them some resources, but we're really established in Ukraine. We don't really have too many Romanian connections. This particular clinician has a connection in Romania and can easily do the group there.
Yeah, so there's just relationship building that has to take place, so that we know that everybody's safe and sound. And thankfully, this clinician is also very well known in his country, and so there's been a good sense of credibility and trust within those relationships.
And I think the idea too is within a couple of years, Heal Ukraine Trauma wants to transfer their program to Ukrainians. They don't want to keep running it as an American organization. They want it to be Ukrainian run. They want people to come in and start educating their own folks and continue growing that network. So the idea is, let's really give as many resources to the Ukrainians as possible. They start building their relationships, they start building their networks, and then they can take over and start teaching people.
Yeah.
How many veterans do you guys have working for you over there, working in the area as part of this, either US or British or whatever? I'm sure there's kind of a coalition of people helping out over there, and I was just curious, like how many veterans are a part of that, helping you guys out doing that?
Yeah, so we've got because Ukraine is having the majority of their men be service members. The majority of the Ukrainian operations team, they're male, are veterans. And when it comes to US veterans, we have a couple that are in country But we've not really been super public. They just kind of come in and volunteer. Some want to maintain their anonymity. Thank you. Their privacy.
Yeah.
I got you.
Yeah, to speak to whether, international military is helping out, we don't really know. We're only on the Heal Ukraine trauma side.
So I was curious, you were mentioning that they were talking about handing this over to Ukrainians and kind of taking it out of US hands. I'm wondering, with all this experience you guys are gathering, maybe what does it look like doing stateside integration with some of this experience you guys have, and maybe what is it you guys plan to bring home, or even if that's possible? I know ketamine treatment is legal in some places here. So I just wonder.
Yeah, well, there's a lot. So before this happened, actually, we developed our own nonprofit called the Healers Home, and have been kind of working with different people around the same kind of education and training that folks need, as well as developing different groups. So yeah, we've been in conversation and developing different programs with different folks, but it's a slow slog as we're moving through different organizations and helping out different people. But it's a hope that we get to bring this and share it with everybody stateside once everything is solidified. And I think we're looking at other countries as well, where if you want to share a little bit about what we've got going on.
Yeah, so we were contacted by a clinic in Israel to help out with the trauma that's going on over there. So we are building another training program with Healers Home. That way we would be able to just, the hope is to stop building all of this and just start making it available for folks so it doesn't get delayed. So we're making it under Healers Home so that way we can just allow access. All the videos are there, all the education is there. People can just start whenever we get contacted by a clinic. So we're building a very similar thing, being culturally sensitive towards military and being culturally sensitive to the country, the culture there. And with that, we're just hoping to start treating people there, and same thing, having clinicians getting trained, and then they can start and going to train veterans.
Yeah. In the beginning stages, that's why you might be hearing us kind of being careful with our words.
Do you guys have content on your websites, the Healers Home, or how would we find that?
We are building that right now. It is slowly coming to works. Unfortunately, with being a full-time grad student, 3 jobs, and him having 17 jobs, we only have so much time. We are taking interns, please. Thank you. But yeah, we are working on it.
Yeah, it looks like we got a comment from Robbie just showing his appreciation for the breath work to psychedelic sessions. So that breath work can be used as a mental bridge past sessions when not on psychedelics. So smart.
It's one of those things that I try to echo everywhere. It's just like psychedelics are not for everyone. We know that, research is showing that, and it's okay that it's not. We don't need to be pushing it into places where it's not. It's a tool, it's an option, but we can get to that same place by using other available methods that we know can get you there.
Yeah. There's something called neurotheology that I really been diving into, where we're kind of looking at the different ways that human beings are wired to have mystical experiences. And it echoed some of my own personal experience when stepping into different vipassanas or sessions and having mystical experiences, that then when I would go off and have 5-MeO-DMT for the first time, realized that I had actually been in this state before, that it was actually in a Zen center in Upaya. And so I came to a pretty strong belief that you can have both. You can have this kind of mystical experience without the use of psychedelics, even though I fault no one for having the route of psychedelics, the ability to actually like meditate for 6 years in a Zen center is a privileged position, rather than kind of stepping into a psychedelic session that's going to make huge changes for you in a matter of weeks.
Thank you, Robbie.
I've never heard of neurotheology. That's something I'm going to want to look into with Brian. Quick back step. Romania, psilocybin. I don't remember the last time I read anything on does the protocol over there, was there any type of integration of like showing people, putting them through sessions so that there's a familiarity there? How does that look?
Yeah, so the session would be similar to our group sessions that we have here in the United States, so that you would have three preparation sessions, in individual session, and then moving through two dosing experiences, one being a psycholytic session, and then have an integration session after that to kind of check in with folks, see kind of what comes up, and then step into a preparation session for a psychedelic dose. And then after that psychedelic dose, having 3 more integration sessions with folks, as well as an individual session as well with each participant.
So it's similar to like how people in the United States with like Heroic Hearts Project are flying to Peru to have access to the medicine. This is kind of the same thing for Ukrainians and Romania.
Mhm.
We're not actually training Romanian clinicians and treating Romanian veterans. It's all Ukrainian going to Romania to get access.
Was that hard to make that connection of like what would be the best place to have that, just to be somewhat close as far as sending people over there?
Honestly, it was up to our clinicians. They are incredibly resourceful, and it was our clinicians' kind of relationships that he had developed, and then brought it to us as just really an inquiry, like what would be possible for me to gain as a supervised experience from you guys.
I think it was also a part of our wonderful team at Heal Ukraine Trauma that like went out and found a clinic and started working with the clinic so that we can at least have a place where our clinicians can go to and get access if they qualify for the medicine. And they did so much background work to really make this possible too.
Right.
Awesome. And I'm looking forward to hear more about Healer's Home. Is that right?
That's right. Yeah.
Israel, all that. That's I was going to ask you like what's going to be in the future, but it sounds like there's quite a lot coming up.
Yes.
Hello, everyone. My name is Max, and I'm one of the founders of Raven of the Sacred Entheogen, which is Oregon's first mushroom church. And through Oregon's first mushroom church, we have some programs where I'm reaching out and trying to help vets. So it's really good to like hear what you guys are doing and see some of your protocol for how you're approaching it in terms of I like how you're using clinicians to train veterans and then veterans to run the programs. And so one of the cool things is that through the umbrella of a church, which is we're a faith-based organization, is that we can get people accessibility to some of these plant medicines, whereas there's a lot of different things that people have to jump through in terms of like therapeutic use of mushrooms in Oregon. And so we're kind of in our infancy, but one of the things and one of the reasons I'm here and I'm looking into what you guys are doing is that I would like to create a similar program where we're getting clinicians to train vets and veterans to help other vets, but it would be using mushrooms instead of ketamine. So that's why I patiently waited until your discussion was done and then just wanted to introduce myself. I think I'm going to be joining these every month and just kind of seeing what's going on. Thank you very much.
Yeah,
thank you.
Super nice to meet you. We actually will be making our 80-something page protocol. We're going to publish it so that it's available for people to use. It's actually a part of my doctoral project as well at Hopkins. So it's very evidence-based, and we're trying to balance it with the medical and the mystical because the research shows that you need both. So hopefully that will be available soon. We are working on also getting that published. And as of right now, we're actually training clinicians to treat veterans, and then eventually clinicians to treat the family unit. So anybody who is related to a veteran in some capacity.
Nice. Also, when you're talking about a mystical experience too, one of the approaches with church and using religion is if you're trying to gain a mystical experience, it's kind of odd to get that in a therapeutic environment. I know that oftentimes works, but I just think that like when you're approaching a mystical experience, when people are facing terminally ill cancer and they have that mystical experience, it's one of the best ways to get them to face death.
Yeah.
And so
It's actually
think that
interesting.
I'm okay with either way, whether it's a therapeutic method or whether it's through religious things. They're kind of doing a similar thing, but under the umbrella of a church, which we're recognized by the state and we're official.
Nice.
I think that we can do some really good work, and so definitely it would be nice to maybe get together with you guys someday and talk in person as well.
Absolutely. Yeah. One of my favorite things about this practice is kind of the intersection of both, as you say, medical and mystical. Because they've already been blended in our history in multiple ways, even more contemporarily when thinking about resiliency factors. In the veteran community alone, our number one resiliency factor actually is spirituality. They've done consistent research at Yale that brings it up each time, and having some sort of spiritual practice or spiritual aptitude has been what's brought people through some of their darkest nights. And I think this practice specifically is the stronghold to really share as much as you can. And that doesn't mean that it's going to be all sunshine and rainbows. There's still going to be a lot of a need for appropriate training and have folks who I think can hold each in a way that doesn't discount the other. Because there's aspects that I think are justifiably cautious when stepping into both spirituality or clinical work. And it's kind of like the blending of wise mind in that sense from the dialectical behavioral approach, where you want not only logical and emotion, you want them both to be working out together.
CBT.
Yes, exactly.
For Alex, Brian, and Zach, apparently, I forgot to mention at the beginning of this, I did bring my crayons. So I'm getting all the notes down. Mike, Jacob, I'm not sure if that applies to you as well, but just wanted to cover the bases there. I wanted to ask you, and I don't know if who wants to answer or not, or what, or if it's appropriate to do it offline, but how many of you guys here are you using whatever alternative methods that you're using for combat related PTSD? Is that something anybody like to mention or talk about? Or
so that you might notice some hesitation in my response, because that's what we do.
Okay.
A little different than anybody that we treat in the US, because right now in Ukraine, almost everyone has exposure to combat.
Yeah.
All we are doing is actually treating related PTSD. In the States, it's a little different. But even still, like in the States, we are using it for people with a combat and without combat.
So there's one specifically where I was the primary therapist at a research trial at the Portland VA for group MDMA assisted psychotherapy, and my cohort that I was facilitating for was actually addressing military sexual trauma. And so having, I think, kind of a third phase trial around what best ailments are going to be treated is, I think, our next goal really is what's really being treated well here. And right now it appears that combat exposure is kind of MAPS has drawn out as well, and other folks in different places has been really successful with this.
Yeah.
Was wondering if any of the other guys had anything they wanted to share, like about that, that related to that. And if that was the reason that, obviously we're all here, but, kind of what that.
It's also why we build those resiliency kind of lenses or practices when moving through the training as well, is that these are folks who also have combat exposure. And these aren't veterans. These are people who are just living civilian lives and dealing with kind of combat as it comes into their cities. There was just not long ago where
I consider that kind of the same. It's
Yeah.
the, your combat's combat,
Yeah.
whether you're a combatant or not.
Right.
That's just the nature of the beast, basically.
So my question kind of follows what Tom just asked about basically where the research has taken you. And you have the opportunity in Ukraine, obviously, to work with highly exposed populations, which maybe you don't get a lot back here in the States because you're working through, like the veteran populations and stuff. And I'm wondering if any of the hypothesis or any of the, like what you thought you were going to get out of the research going into this had changed based on the research that's been done, and like how you came to that. What has become more efficacious through the process?
It's a really good question.
Yeah, it is.
I feel like starting at most of the people that we end up treating that are veterans, one of the first traumas that comes up is always childhood. So regardless of whether you've had combat exposure, or whether you haven't, a lot of times what it comes down to is that childhood trauma. So I feel like that's a big thing that maybe the research hasn't dove into. I'm trying to think back through all those thousands of research papers we read, but I want to say that's a beautiful thing that I didn't really expect to be treating that consistently keeps popping up, which
that's where my mind went. There's this universality of like the human experience that always kind of comes back around, and I think it's really important to have cultural sensitivity and to find the nuances of each subjective experience. And at the same time, there are these shared core experiences that I think so many of us go through that I'm reminded of here and when we do our work in Ukraine, that our childhoods are just brought out each time. The kind of core self that is developed has been a consistent reminder of the impacts and beauty that we get to work with folks. I think for me, at least, the need for group experiences, I think it's really valuable to have some one-on-one time with folks in case they're having trouble kind of sharing or in a different place of expressing themselves. But specifically with psychedelics, there's a bonding agent that's been there since the inception of this work, that for a lot of tribes that had warriors, they were having psychedelics before leaving and going off to defend their tribe. And then coming back in and having a ceremony to reintegrate into their tribe and community. And having that experience, I feel like is akin to the bonding agent that's necessary in collectivistic cultures, specifically in traditional cultures like Ukraine, where collectivism is very prominent. And the effects, I think, in any therapeutic work when it comes to group healing, in my experience so far, just anecdotally, is much more powerful than an individual session.
I also want to bounce off that and say, in a community or in a country in which individualism is so relied upon, we end up isolated, our mental health rates go up, all of this stuff we see as effects of being too individual rather than having safe communities. By creating a group, you now have a solid place to fall back on. You have people that you've gone through a shared experience with and grown and healed together, people that can keep holding you accountable, and you have a safe place where you can just be sometimes and rely on other people. And I think that's super important in this country, to start building some of these communities where people can just be safe and rely on their neighbors, and start bringing some of that community back.
Yeah.
Can I ask a follow-up then on that? So working with the two separate populations, one that's, say, been to combat, or one that's been into the military and gone to combat, and one that's just a civilian population affected by war, by conflict, have you seen any kind of cognitive life cycle differences in the way that they respond to the treatment? So somebody who's maybe, in young adulthood gone into the military and doesn't have that portion of the life cycle that somebody in Ukraine who was just living their life and paying rent and going off to this, and then all of a sudden this happened to them. Has there been different outcomes?
So there's been no specific research done on that specifically, but what we do know about the pathology is that your training and exposure for resilience. So for instance, active duty personnel that have moved through combat experiences show a lower rate of post-trauma than reservists who don't have consistent exposure to specific training operations in comparison. And so people who even like jump into different reserve units may actually have a harder time coming back out after a combat experience due to that difference in training and exposure.
I'm trying to think about like my experiences. I forgot to mention I'm an acute psychiatric nurse at the VA. I've been working with veterans for my entire nursing career. Little important fact. And I'm trying to look at that and compare it to what we saw in Ukraine. And I think the only thing I can really think of is actually similarities between like when the trauma happened, whatever that specific trauma can be, and developmental stages. Like I'll see people get stuck at certain developmental stages in the US based on their trauma. And actually in Ukraine too, they'll get stuck. And what we see with psychedelic-assisted therapy is that they're able to start continuing to grow through that. You're removing that limitation and they can continue maturing.
That's a really great point. So there's, for my veterans out there, the sense that moving through like a scud attack or a mortar attack, where you don't have an enemy to engage after that, you're just thud, thud, thud. That's a stuck point for a lot of folks. And actually folks who have been able to engage, neutralize, and move on don't really have a stuck point in that sense. Their nervous systems have a bell curve to operate from.
Mm-hmm.
I do have one real quick question for you guys, because you're using the substance ketamine, but I've seen research that classical psychedelics like psilocybin and lysergic have a much stronger binding effect with like TRKB, which gives you the antidepressant effect and the long-term serotonin uptake. So I'm wondering, like, have you guys thought about doing any, or is it even possible to do work with something like a 4-AOC DMT, something that might be synthesizing and otherwise
That's
not,
something that
not
we
tolerated substance?
Yeah, it's something that we were hoping for, but are just limited by the
law.
regulations right now. And it's why we created the protocol in the way we did for the flexibility of mixing and matching the medicines. And really just holding the model of harm reduction and psychotherapy around it. There's I think for me, when you're looking at classic serotonergics, that's your bonding agent, as you say, Brian. The impact is going to be a little bit different. I don't want to knock ketamine completely,
Well,
but there's just a different response to it in the body.
I think ketamine for depression too, from all the research that we've been reading, it has a really great binding potential to the NMDA receptors and the glutamate receptors. So specifically the receptors in which are found in pathologies of depression and acute suicidality. So with what it's allowed for right now in Ukraine, it's the best possible medicine that we can get until we can have access to psilocybin and LSD and MDMA, which then we can start tailoring for the specific disorders that people come in for.
When thinking about glutamate too with ketamine, so glutamate is what we often need to remember or learn. And it's something that I think really helps with the process of integration, like really remembering what this experience is like for you and just what you need to put in place moving forward. You'll have that because of the interactions with ketamine.
That was what our whole show was about last month, was kind of the glutamate interaction with BDNF and then ultimately binding with TRKB. So it's pretty fascinating when you just watch the chain of events. You're like, oh, that makes a lot of sense.
Yeah, right. Love it.
Shout out to our boy Jake. I see you, brother.
Yeah, I saw Jake come through. I'd like to thank everyone that came through from the audience today for joining us. If you're going to be watching this on YouTube, want to join us live for a future show, feel free to visit our meetup page. I'll leave the link for that so you can see our future events coming up on the calendar. You can kind of plan out what you'd be interested in joining us for. We don't have anything planned as of yet for next month. We'll see what we throw up soon. But But again, thank you, Neeka and Zach, for joining us. Great conversation, great talk. Good to see you guys. We meet on the third Sunday of every month at 11 a.m. So we'll see you guys next month. Have a good one.
Take
Thank
care.
you. Great time.